In today's video, we will be discussing bowel obstructions, the common causes, pathophysiology, clinical features including important red flags, as well as relevant investigations and management. A bowel obstruction is a partial or complete blockage of the small or large intestine which inhibits the movement of bowel contents. This obstruction can either be mechanical or functional. Mechanical obstructions involve a structural barrier, for example a mass, which physically inhibits the normal passage of contents through the bowel. A functional bowel obstruction, known as a paralytic ileus on the other hand, occurs when there is impaired peristalsis, even though there is no physical blockage. Peristalsis referring to the constriction and relaxation of smooth muscle within the bowel, creating wave-like movements that propel digestive contents through the intestine. The common causes of bowel obstructions differ between the small and large bowel. For small bowel obstructions, the most common cause is adhesions. Adhesions are scar-like strands of connective tissue that cause bowel to adhere or stick to adjacent bowel segments. A common risk factor for adhesions is previous abdominal surgery. The second most common cause of small bowel obstructions are hernias. A hernia occurs when an organ or tissue pushes through a weak area of surrounding muscle or fascia. Fascia meaning a thin connective tissue layer. When part of the bowel protrudes through a weak area within the abdominal wall and is unable to be reduced back into the peritoneal cavity, this is called an incarcerated hernia and is much more likely to cause an obstruction. Other causes include malignancy, strictures from inflammatory bowel disease, and intussusception. Intussusception is rare and typically occurs in children and infants, for example from a congenital anomaly known as Meckel's diverticulum. It involves one part of bowel sliding into an adjacent part of bowel in a telescoping action. This is very rare in adults, and when it occurs, it is typically due to an underlying condition such as a polyp, malignancy, or adhesions. Large bowel obstructions, on the other hand, are most commonly a result of a malignancy. The second most common cause is diverticulitis, where outpouchings of colonic mucosa become inflamed. Other causes include a volvulus, which is when the bowel and its supporting mesentery, the peritoneum attaching the bowel to the posterior abdominal wall, twists around itself. Adhesions, strictures, and fecal impaction can also cause a large bowel obstruction. Functional bowel obstructions, such as a paralytic ileus, are most commonly the result of an abdominal surgery. However, electrolyte imbalances, other surgeries, medications such as anticholinergics and opioids, as well as inflammation of the bowel can contribute to a functional obstruction. Moving on now to the pathophysiology and subsequent red flag clinical features to be aware of. When there is a bowel obstruction, whether it is mechanical or functional, there is stasis of bowel contents proximal to the site of obstruction. Gas accumulates proximal to the obstruction. This gas can be from swallowed air as a byproduct of bacterial fermentation, etc. There is similarly an accumulation of ingested gastrointestinal contents proximal to the obstruction. If there is complete obstruction of the bowel, there will be an absence of bowel movements and no flatus. This is known as obstipation. If the obstruction is partial, there will be a reduction in the number of bowel movements, and there can still be flatus. The build-up of gastrointestinal contents and gas, which is unable to progress past the obstruction, causes the pressure within the lumen to increase. The abdomen will be distended and tympanic or high-pitched tinkling bowel sounds may be present due to the accumulation of gas. The contents within the bowel then draw water into the gastrointestinal tract. This is known as third spacing and causes dehydration, as the water is now in the distended bowel instead of intravascularly where it should be. The continued distension and pressure, as well as the peristalsis taking place proximal to the obstruction, continue to place force against the obstruction. This can cause nausea and vomiting. When someone vomits, they lose certain electrolytes, including sodium, potassium, hydrogen, and chloride, in addition to fluids, adding to the dehydration and also causing hyponatremia, hypokalemia, and metabolic alkalosis, as well as hypochloremia. They can also have significant abdominal pain, as well as hyperactive bowel sounds proximal to the obstruction, and reduced or absent bowel sounds distally. Note bowel sounds can be absent in a functional bowel obstruction. The increased pressure within the bowel compresses the veins and lymphatics draining the intestine, which ultimately leads to compression of the capillaries and arterioles. This decreases bowel perfusion, causing ischemia and potentially infarction, necrosis, and perforation. Perforation can cause peritonitis, presenting as guarding, rigidity, and rebound tenderness. There is also potential for sepsis. We have covered the key clinical features and red flags for bowel obstructions within our pathophysiology overview. However, it is also useful to look at the clinical differences between small and large bowel obstructions. In a small bowel obstruction, the pain is typically colicky, meaning it comes and goes, periumbilical, and can be relieved by vomiting. In large bowel obstructions, the pain is more likely to be continuous. Nausea and vomiting occur early in a small bowel obstruction and typically are of a larger volume. Vomit is also typically bilious. In large bowel obstructions, the vomiting is late onset and there is potential for fecal vomiting, meaning that there is feces present in the vomitus. Distension is more significant in large bowel obstructions and onset is earlier, whereas in small bowel obstructions, the abdominal distension isn't typically as severe. In a large bowel obstruction, constipation typically has an earlier onset. The more distal, the more likelihood of constipation or obstipation. In small bowel obstructions, constipation is a later onset clinical finding. On to diagnostics and management now, starting with our initial management. As we have discussed, bowel obstruction can lead to bowel perforation, strangulation, as well as sepsis, so it is vital to diagnose bowel obstructions early and consider them an emergency. As always, in an emergency presentation, you start with a primary survey using the A to E approach and stabilise the patient. Remember to consider life-threatening differentials for bowel obstruction at this time, including an abdominal aortic aneurysm and pancreatitis. In particular, for patients with a bowel obstruction, ensure they are nil by mouth. Gain IV access and take relevant bloods. These include a full blood count, VBG looking at the lactate, as well as for metabolic alkalosis, EUCs, LFTs, lipase, BSL, CRP, and blood cultures. You should also provide fluid resuscitation. Nasogastric tube insertion is not usually necessary, however can be used for patients with significant vomiting or distension. Antiemetics and analgesia as needed. Antibiotics if evidence of peritonitis, fever, or leukocytosis. Arrange for an urgent surgical consultation. Then electrolyte repletion depending on lab results. Further management and diagnostics include imaging studies, starting with plain films. Initial imaging should include abdominal x-rays, ideally erect, and a chest x-ray in the erect or upright position. On the abdominal x-ray for a small bowel obstruction, you are looking for dilated loops of bowel proximal to the obstruction, and these should be greater than 3 centimeters in diameter. Multiple air fluid levels. Note these will not be visible in the supine view, only the erect view. You're also looking for distal collapse. In a large bowel obstruction, you will see proximal distension, greater than 6 centimeters in the colon and greater than 9 centimeters in the rectum, and distal collapse, however there will be limited or no air fluid levels, as the large bowel is the primary site of water absorption. You can also see a volvulus if that is the cause of the obstruction. The erect chest X-ray is used to screen for perforation. It will show air below the diaphragm indicating pneumoperitoneum. Regarding further diagnostics and management, CT abdomen and pelvis is the gold standard investigation and provides more information. It can be used to identify the exact location of the obstruction, whether it is partial or complete, as well as the etiology of the obstruction. An abdominal ultrasound can be considered in hemodynamically unstable patients. Definitive management is going to depend on the cause of the obstruction. Options include surgical management, endoscopic interventions, or supportive care for patients with uncomplicated partial obstructions or uncomplicated complete small bowel obstructions. So today we have looked at bowel obstructions, the etiology, pathophysiology, investigations, and management. Thank you for listening, and please let me know any questions you may have or future topics you would like covered.